What's happened in sterile processing and operating room universe? This is Hank Balch with Beyond Clean and First Case. Excited to welcome you to the pre-session of PYROTECH 2021. We've got a fantastic event planned for you right now and all day tomorrow. A tremendous global virtual conference is bringing together operating rooms, sterile processing, all around the topics of technical excellence in our departments. It's a 9 CE event. So this is your last chance to get registered to watch everything live. You're obviously watching this, but tonight, Friday night, if you see this, you still got time to jump in, go get registered at educate.beyondclean.net/PYROTECH 2021. We'll put the link in the bottom of the feed as we get done here. Go get your registration and join us for this terrific event. Obviously, if you're tuning in, you've probably got a little idea what we're going to talk about on this session, the dirty secrets of IFU non-compliance. And yeah, we're going to be talking about the dirty secrets, but as Beyond Clean, we're going to be talking about how to overcome the dirtiness and the challenges to take instruments beyond clean. And just as we love to say, beyond clean, we fight dirty. So we're going to be talking dirty tonight, but with the intention and the plan to fight dirty. So really excited to have everybody on the panel discussion tonight. And without further ado, let's welcome them in. I'm going to let them introduce themselves, and then we'll jump right into the meat of the show. As a reminder, we love to know who is watching and where you're watching from, and especially because this is a collaborative event, I'd like to know what role you have in surgical services. Are you a sterile processing tech? Are you a surgical tech? Are you an operating room nurse? Are you a department leader? Give us a shout out below. And throughout this session, we're going to be in the comment section as well with you answering your questions, give them some follow-ups, linking to resources. It's going to have a lot of fun. Thank you again for joining us. So let's bring in this panel of subject matter experts. We're going to start here with Ken. Tell us who you are and a little bit about yourself.
Well, hi, Hank. Hi, Beyond Clean World. My name is Ken Batten. I've been in sterile processing now for just under 6 years, and I'm currently a manager educator.
Awesome. Welcome, Ken. And Jardine, go ahead.
Hi, I'm Jardine Carlton. I am in Rochester, New York, and I'm currently a operations manager. And in about 3 days, I'll be the quality education assurance manager.
Hey, congratulations. Awesome. Thanks. Awesome. Welcome to the discussion. Up next is Michelle.
Hi, everybody. Beyond Clean Universe. My name is Michelle. I have been in the field for about 22 years. I am currently the surgical processing educator for a hospital in Washington.
Awesome. Welcome. And then Andy.
Hey, everybody. Good to be back, Hank. Thanks again. I'm excited to do all this with all of you. I've been a part of this space just shy of 30 years, either running the departments through a company and for healthcare systems or hospitals, or dealing with instrument repairs and replacements. And then recently, a founder of a company that runs a software that help us sterile processing professionals. It's called Bluefin, and it's an IFU management system, intelligence structure that we can use.
Awesome. And then we got one more coming in here with us. Lisa, tell us a little bit about yourself and your background in the sterile processing space.
Hi, I'm Lisa Santiago. I'm the Director of Sterilization and High-Level Disinfection for the Atlantic Care Surgery Center Network, and we do a lot of work across the Atlantic Care system. Been doing this for close to the last 15, 18 years on a director level, but I've been in surgical services since the start of my career as an OR tech.
Beautiful. Awesome. Welcome. So as everyone can see, we've got some all-stars on this panel with great background and insight. And again, we're going to be talking about the truth here, the dirty truth of what our challenges are around IFUs. But before we get into that, we need to set the table because there's going to be all kinds of different people listening in from the OR side, from sterile processing, from the manufacturer. brand new technicians into the space, possibly even folks who don't even work in the industry yet but are considering it. So let's set the tone. What do we mean when we say IFUs or MIFUs, depending on where you are in the globe? What does this mean to us technically? And then what does it mean practically? And anybody can jump in.
I'll go ahead and start, I guess. To me, an IFU is exactly what it stands for, the instructions for use, right? How I like to refer it when I'm teaching my techs, it's going to be your Bible for that particular instrument, how it needs to be cared for, how it needs to be fed, how it needs to be watered, all the things to make it grow and stick around for as long as possible.
Great. Yeah. So what are the areas that an IFU is applicable? Like, I understand that, you're saying it's the basics, it's everywhere, right? But kind of who can give us some insight, some practical insights on kind of where and when you would use an IFU?
Yeah. Hank, if I could jump in on that one, kind of capitalize on what Michelle had shared. I kind of view that IFU as that validated scientific information available that's been proven for us. And the idea behind it is to reduce the risk for patients. It obviously helps us, reduce that biofilm, bacteria and viruses and so forth. But in theory, you kind of look at that compliance structure, and to answer your question is, at this point, we're supposed to be doing it for all instruments. And unfortunately, as an industry, we don't currently. And I know we're talking dirty truth, but unfortunately, we're in a position that we should be doing it for all instruments, just not a category or one or a few within that tray. So in my opinion, we should be doing it for all instruments.
And to jump in, Hank, tagging on to exactly what was said, we should be doing it for every piece of equipment, every instrument. And again, we're talking about throughout the industry, but, for me, it is the Bible on literally everything we do moving forward. Every IFU, along with, ST79 is the standard on our practice, and it is the Bible and everything we do. And it's, and it's not only that first time you're looking at that IFU, is continued updates. It's checking, it's rechecking, equipment changes consistently. And, for me, it's there is no other way. It's a black, it's a white in this. Unfortunately, fortunately, there is no gray in sterilization. So it's what we need to do every time.
And Hank,
so let me
real fast, if you don't mind.
Yeah, go ahead, Ken. Yeah.
The IFU is the bridge between the manufacturer and sterile processing. It is how the manufacturer can talk to every sterile processing department in the world at this point. They can say, this is how we say things need to be done. And short of every single manufacturer going to every single sterile processing department, they can just make their IFU. And that is how they can tell. They can make that bridge between them and the sterile processing department. That opens that communication aspect between both the department and the manufacturer.
Great. Well, I want to go into something that I've heard a couple of times kind of assumed or alluded to, but let's just come out and say it. Everyone on this panel, from what I'm hearing, is agreeing that in the industry today, in daily use of surgical instrumentation, there is non-compliance happening today with manufacturer IFUs. Is that correct? Does anyone disagree with that statement?
Fully
okay.
support.
Not out of a malice kind of way. Like,
okay, yeah, go into that.
We're not purposely being non-compliant. It's just there's things that happen.
To plug that, exactly what he's saying, that's probably the whole reason. Well, that is the whole reason why we're having this conversation, right? And I think the reason why it's not done in malice. The reason why is because there's so many differences, right? It could be the same instrument across 4 or 5 different manufacturers, and you're going to have 4 different sets of instructions. So, how do we know which one is the one that you use? And if you have multiple manufacturers in a set, how do you know, do you have time to separate those things and do all these things? With as fast as we're having to turn and burn for the OR, that's just not, it's not a reality right now. Unfortunately, it's not feasible.
I would
It
have
is,
to
and-
agree.
And just,
Go
going
ahead.
back to that for me, if you think about it from an everyday perspective, the IFUs are certainly not an easy read for anyone.
No.
For individuals that are as experienced as most managers, directors are, people that have been doing this for eons, they are not an easy read. And even at my stage of the game, I consistently, when I review IFUs, I also have my managers review IFUs. I want a second set of eyes on that. And to be perfectly honest with you, they're not an easy read. Could they make it any more difficult for us? So your average technician that is reading this on an ongoing basis, they look for guidance. We need to be there to provide that guidance, but manufacturers make it very difficult. So I go back to exactly what everyone else is saying. There's no sense of malice in it. It's not a sense of negligence if you've seen it throughout the industry. It is multifaceted, a lot of it based on the complexity of the IFU for every single instrument you're using. It's a completely overwhelming process.
Absolutely.
I want to throw back to Jardin. I think you were going to add in something there too.
I was just saying that it is not, I agreed, it's definitely not out of malice. It's just more out of inconvenience that there's non-compliance. It's too much information in most circumstances to comply with. And so we usually just take a shortcut and adapt our own, pathways to make it easier for us.
Right.
So, Hank, if I could just twist it a little bit, I'd like to twist it a little bit. And I certainly agree with 100% of everybody's comments. I want to be the first to say I believe us sterile processing professionals, we are overworked and underpaid. So you put a buzz out that to everybody out there. But I also see from my side of it, I look at the industry, we kind of treat everything as a one size fits all, and that's not good enough. We have bad habits, bad behaviors, bad thought processes, bad training. We have bad excuses. So I look at this as we've got a multi-layered situation that we want to do what's right, most of us. It's very difficult, or I call it, actually, it's impossible for us to follow IFUs. But I also look at the behaviors of our industry. We need to change as an industry, and we all care, but we need to care more. We need to make sure we don't use the excuses as our crutches, and that we actually pursue a better outcome for the patients. And that would be a compliance structure and following these IFUs to our best ability.
I think to add on to that too, by us following, as the technologies evolve, so we need to evolve with it, right? These things get more and more complex. These devices get more and more complex. We need to do the same thing. And while we're underpaid, right, we're saying that, like, as we develop ourselves and we learn and we gather these skills and become stronger and more knowledgeable as a not organization, industry. But as a industry. Thank you. Yeah. Yes, thank you. I think that will only help to bring light how important our job is, and hopefully maybe in the future put us up, paying us what we should be paid, because this is not just a dishwashing job or, a step up from EVS, which a lot of people, when because I'm the department educator and I've also ran and taught a residency program. And a lot of people who come in as hospital transfers just think that it's, a little bit harder than EVS. And it's like, oh, no.
I also teach an online sterile processing course, and we work with extern students all the time. And to be perfectly honest with you, one of the things I struggle with, and I say this on a consistent basis throughout our industry, and I've really sort of tried to model this throughout my career, is when you hear individuals talk about, what a tech does, or you hear complaints come from technicians or the industry, and throughout every iteration of my career, I've heard, we're not respected, and that has happened many times. But one of the things I don't think that we've done enough of, and I don't think we've pushed hard enough, is consistent certification. And I'm in New Jersey, so that was one of the first states to do it. But throughout the country, nationally, certification has not been pushed, and you will still see throughout the country. There are many institutions that do not make that a priority. And for me, certifications, multiple certifications, progressing through your career, that is, to me, how we're going to have this industry, the start of having this industry respected, so that you are not saying it's a glorified dishwasher, it's a glorified housekeeper.
Right.
You know, the importance of any reprocessing area. The other thing that I don't think we focus on enough is high-level disinfection. You know, every sterile processing technician that, you know, is certified, that comes out of a well-modeled training program, should be prepared for sterilization and for all forms of high-level disinfection. It's not just sterilization today. It's forms of high disinfection as well. So
I want to tap in though to
Sure.
your point about certification as it connects to this challenge of IFUs, right? Because that's really, we've got a question on this panel like around the gaps, and we've already identified, you know, these things are hard to read. It's a complex issue because oftentimes there's not just one manufacturer in a tray, there's multiple manufacturers, even if it's the same instrument. But if the answer, if what I'm hearing, you know, from some of y'all is part of the answer to this is higher certification rates, well, then we have to answer, is there a gap in how we're doing certification in training to the IFUs or training about the IFUs? And that's actually the question that's on the bottom of the screen is, how can we talk so much about IFUs? Anyone who has been certified knows it's kind of cliche. If you don't know the answer to the question, choose IFUs because that's, you know, that's likely going to be the answer. So it's definitely prioritized in our textbooks in an industry education. And yet we've just been talking the last 20 minutes almost on it's almost universal and systemically not followed for all the reasons that we're kind of starting to discuss. So I guess the way to position that is, are we missing something today in our certification curriculum or education curriculum around this, or are we doing everything we can in terms of that? And now we need to have different discussions outside of just
I'm sure we are. You know, I've seen many techs, experienced techs over my career, but techs coming out of new programs, again, when I teach, but techs, you know, experienced techs, you start talking about verifying and testing, and they'll look at you like they've never heard of this in their career. And are we missing that when we teach programs? Are we missing that in our certification process? These are all pieces that sometimes I find and have found over the last 10, 15 years that you talk to technicians, and this is not a process they're aware of. This is something maybe a supervisor did or a manager talked about, but it's not something they're even aware of how that process works or why it's being done. So I think that's an opportunity. And that goes into IFUs. You know, when you get new equipment that comes into your facility, loaners, any of those areas, trays you've never seen before, you know, verification testing needs to happen. And you talk to techs about it and they look at you strangely, and it's not something that we focused on.
Like a deer caught in headlights. You know, I want to piggyback on what she's saying with that as far as experienced techs. One of the facilities that I came into, a while back, when I first come in, the first thing I do is watch and observe, right? See what's going on, what practices are, just kind of see. And I asked the question, what's the IFU say on that? And just like she said, an experience, many years, a deer caught in headlights. And so I think that we definitely maybe need to possibly make our programs have, maybe add these units to them, or have it added to clinicals where they've got to physically, go figure out how to figure out where to get that IFU. And I've also had people who tell me the answer, SPM tells me, or SensaTrack tells me, or whatever. Well, and then my next question to them is, well, how does that know what it's supposed to be? Somebody put that information in. Is that information still valid? When did they input that information? So many questions. So I think we need to maybe find a way to hone in that type of critical thinking and that training where, okay, if I can't find it here, where can I find it next? Because also you have people who say, the IFUs are on one source and only my supervisor has that password.
Right.
That's not, everybody needs that password. I have
That's
put that
correct.
username and password on every computer we have in our department.
Correct.
Everybody should be able to access that.
So I see some movement from Ken and Jordan. So Ken, you go first.
If you don't mind. I actually want to piggyback off a couple things that some people said earlier. Somebody made the comment that, the manager will look at the IFU, then they'll, delegate down and say, hey, can you relook at this too and get your eyes on it and everything. And I think doing that, involving your technicians to see what they think is a good way to get them involved, get them seeing one that does multiple things, that shows the technician what the IFU looks like. So then they can't say that, they've never read an IFU. I've heard that plenty of times. And, IFUs may be complex, but they can also be broad enough to where they can be open for interpretation. I have seen plenty of IFUs where I read it and I'm like, okay, this says we have to sterilize at this. And then somebody else reads it and it's like, no, it says right here that it's sterilized at that, but we're reading the exact same paper.
Yep.
And it's so, I don't want to use the word vague, but it's vague. Like they don't necessarily tell you exactly. It's recommended, it's minimum, it's a lot of open terms that I think should, that's a big word. If you were to close that off just a little bit, it might be a little bit easier for people to understand some of these IFUs.
Agreed. And, they'll talk about STERRAD, but, there's a lot of times technicians are not aware of a STERIS crosswalk. They're not aware, that you can look at other things. And I go back to, the importance of IFUs, which a lot of times determines how you purchase equipment. What your sterilization equipment is. Well, I don't have that opportunity. I don't have the ability to sterilize that equipment. I don't have that opportunity to be able to do this. Or is it going to slow my process down completely? If this is a soak for 45 minutes, how as fast as we have to turn this over, how am I? It requires 3 rinses. How are we going to be able to do this? So a lot of times,
need a new sink.
I think we advance this industry by being a participating group with a lot of different areas within a hospital, how we purchase equipment, why we purchase equipment, how it works for the flow in SPD, which in turn then works for the flow of an OR, then works, we are that stopgap piece where everything flows from. And so we talk about OR turnaround time. We talk about all those things. Well, it starts with the IFU. It starts with that IFU, the complexity of it, the process basis of it. Should we purchase that equipment? Is there an alternative? And we go through that to make efficiency for SPD, but also efficiency for our ORs and moving forward. So I think that's how we advance our industry. We become a piece of the table. Moving forward.
I also think that we advance the industry by teaching critical thinking. I happen to teach sterile processing currently. And one of the things that is focused on a lot in nursing is critical thinking. That's not so much pushed in sterile processing. We're kind of taught to be robots and automatic and not so much critical thinkers and analytical thinkers. And so I think that's what will really propel our industry. When I hire people, I'm not looking for you to be animated or automatic. I'm looking to see, are you a thinker? Do you possess the skills that it takes to pull things apart and look at them as individuals and then put them back together and make them make sense for you? Not so much for me, but for your own benefit. And then also, I think manufacturers can propel our industry by developing a sense of reality. What is really going to happen versus what you think or you hope will happen. I deal with this in management quite a bit with directors and high-ranking people in my healthcare system. I can very quickly deductively say that is not going to happen because I'm still a tech. Even though I'm in a ranking position now, I'm still a tech in my mind. And so I know what I'm going to do and what I'm not going to do. And although that may not, impress everybody in terms of just being integral and being honest, it is very much a real thing. And so if you're writing instructions from the standpoint of speaking almost another language that nobody can understand or a scientific language that nobody can grasp, that it's just not going to happen. And so the way that we approach this even from a text perspective, we approach this in very layman terms. And so, is it stainless steel? If it's stainless steel, I'm just going to brush it. I can put it in cavitation. That it's just that simple in our thinking. So if you're writing in scientific expression and you're writing in you know, healthcare language that nobody understands, it's completely beyond our world of reality. And that's why we're intimidated by approaching that. So I think we have
That's a great point.
Make things so trivial that everybody gets it. But people have to be so analytical that when it's unattainable, we know exactly how to pull this apart when we need to. But we don't want an everyday struggle.
Yeah.
Right.
So I do want to tie that in to something that's come up a number of times through Beyond Clean podcast, and that's the reading level of our industry. And this goes into, you know, some of the demographics and everything that we've been talking about, you know, but even back to the certification point, you know, there are two certification agencies in our industry who have two different textbooks. One of the textbooks is written at a college reading level, and the other textbook is written at an 8th grade reading level. Same content, but they're written in a way that a larger swath of our industry can read it and comprehend it, and thus do it, as opposed to, and I just cannot agree with you more, you know, for the IFU structure and development is, who is your audience for these IFUs? Is it like FDA regulators who will say check, or is it the user themselves? And if it's the user, what is that demographic, and can we address them? Same content, right? We're not talking about like a dumbing down the content. If you can't communicate up and down that chain of demographics, then you don't really understand what you're saying either. If you can only say it one way, right? It's just about that skill of communication. So I just really wanted to bring that up and say huge and continual issue, not just IFUs, like across the board, and how we teach in sterile processing. Michelle, you got your hand. Go ahead.
Piggyback on what you guys are both saying, because you both segued into what I was going to say with that. You know, for the instrument manufacturers, by putting that at a level, because we have such diversity in our industry, right? And so many different walks of lives. And a lot of people, English is a second language.
Exactly.
And I've seen a lot of problems, you know, teaching firsthand, where the struggle is understanding that jargon that's just so complex for them. So if you put it in a language that's easy for everybody to understand, you're more likely to, one, get compliance. Two, they're going to do the right thing. And if you build your these companies, if they build their IFUs and they do their validation testing under real SPD conditions, right? Not the scientific 10 to the nasal to the negative 10, 6, or all of that stuff, and really do that, I think we'll end up having safer patient outcomes in the end too. Like, it's a domino effect, right?
Yeah. So that's the segue.
We're going to do it.
I want to bring Andy back in here, because the impact to the patient here, I do not want to miss in this conversation. Like early on, like we kind of laid out and said, okay, there's a lot of non-compliance, but I want the public and the patient to understand this. You know, what we're saying today is you have a high likelihood, if you're having a procedure in a hospital in the United States today, one of your devices that's being used on you was not processed according to the validated instructions from that device manufacturer. If patients knew that, Andy, across the board, how likely would they be to sign up for elective surgeries today? Just kind of curious on your thought on that.
Yeah, and if I look at the data that we currently have, unfortunately, and again, I'm going to point the finger at me, everybody, because I'm guilty as a part of this industry and our teammates. We have recognized, and this is something that I've noticed for years and years, but now that we're having data actually put to it, it is very unfortunate that we're seeing 48% of the trays currently going through sterile processing departments. And I have now data from about 20 different locations. It is unfortunate that we are falling short roughly 48% of the time on these trays. So that's almost, it's half the trays.
That's
and
scary.
Because the IFUs are complex. And I'm sorry?
That's only 20 locations.
That's only 20. So kind of putting everybody into a bucket. We all kind of do things very similar. I can't say there's a true standard of care when it comes to sterile processing, because we do guess. But now that we're looking at data and really truly understanding the in-depth details of IFUs, it is unfortunate that we are falling short as an industry. And the nice thing is we want to give our teammates tools that allow us to get better at what we do. And at 48%, it's not a good enough number, obviously. So we need to, as an industry, look at, from an education perspective, from training, how to communicate. And then ultimately the goal on this Beyond Clean is how do we get the manufacturers to hear us when they write these IFUs, to make it more cookie cutter so we can all get it and we can all follow it, and we don't have to decipher kind of curveballs that they throw at us during or within these IFUs. So it is unfortunate, but we are falling short.
I mean, shocking statistics, right? Like that number alone, I haven't heard that nearly 50% number before, so that's news to me. The numbers I have heard are the percentage of surgical site infections, the common HAI stats, all of that information that is enough to scare me. You know, like the whole, it's the analogy of enough people die every day from preventable medical mistakes to feel like one of those big airplanes. I don't know, like 757, right? Yeah. So every day, if you woke up and on the headline news, a 757 crashed in the United States, how long would it take you to stop flying? Well, I'll tell you, I already don't like to fly. I don't need to see any more plane crashes, but it's not going to take very long for that many crashes every single day to stop us. And yet this is happening all around U.S. healthcare. And now, Andy, to your point, we've got data to prove the non-compliance in sterile processing. We got this whole panel saying, hey guys, we're trying. You know, we're not waking up in the morning saying we don't care and we're not going to pay attention and we're going to take all these shortcuts. It's we are trying our darndest, from how we're educating to how we're doing policies and procedures to do this right. And the phrase, I think you even used this early on, Andy, it's impossible. Like it's
the way it's currently structured today. It's impossible.
Compliance. Yeah.
Right.
And if I can, on that note, with what you both said,
hey, Ken, I think your audio chopped out there. Can you still hear us?
He looks frozen.
Okay. Yeah. I might have got frozen. It is snowing up in Pennsylvania today.
I just wanted to say one of the things I stress, and I've always stressed with my employees, but definitively also with my students, tagging on to IFUs in this. IFUs are, whether they're written in a complex form, whether they're written in an easy to use form for better understanding, are only as good as the technician with ethical conscience. And that's really what it comes down to. So one of the things I make a very strong point of when I teach, as well as when I interview and hire, is ethical conscience, and performing every duty as if your parent or child was going to be on the table. And that's sort of what I stress all the time. If you're not going to walk into this role with ethical conscience every day, don't do the role. So the IFU is only as good and as effective as the user performing the job and actually, interpreting and carrying out the directions in the IFU. So
that's the moral harm, to use like a philosophical category here, that we're doing to technicians today, because you do got a lot of ethical technicians out there who, just like you, they want to do the right thing, and we're being forced every day to compromise our ethical standards because we don't want this used on our family member. We don't want to use on us, but there is no way forward, to Andy's point, with the current resources and structure and landscape of this IFU conversation. So it's more than just that kind of cold non-compliance. It gets to the heart of the individual and the industry to say, this is breaking us like ethically and morally because we don't want it to be this way. And then here it is. So yeah, that's a fantastic point, Lisa. I know we've been talking about gaps a lot, but I just wanted to give the opportunity before we move on to another question. Are there any more gaps that we haven't already surfaced that we need to bring up that come up in just that day-to-day working with IFUs or other frustrations that we haven't mentioned?
Loaners.
Loaders.
Compliance with vendors when they bring in their loaners. This is the bane of my existence.
Yes.
Agreed.
We get so many trays come in, and there are never any IFUs provided, and staff has never seen this tray before. They have no idea, and so it's just, oh, does it look like it's steam? Does it look like it's Sterile?
Right.
Bucket, throw it in, and here we go. And these surgeries, typically what we're getting loaners in for, orthopedic cases, neuro cases, and the mortality rates on these cases going onto the table with everything perfect can be up to 50%. So by us not having these IFUs and having the tools to make this right decision, like it's putting us in that situation, like you said, as ethical, technicians, where we're having to cut that corner and do what we think is best, but we don't know. We don't have that IFU in front of us. And when you ask that rep or that courier to give you that IFU, or, you have different programs or that are internet based where they could do all of this stuff for you ahead of time, it's still not being done. And I guess I wish. It's just so frustrating.
It is. And I will tell you some of the challenges. It used to be you had the same rep come in and deliver your trays and inventory the trays with your technicians and be able to do that. Well, that's not the case anymore. FedEx sends them in. There is no rep. Who's your resource? Yep. Where do you go with this? So my managers, my leaders, and then of course myself, throughout my career, but I am always, our policies reflect the necessity to have those loaners in with, by 24, no more than 48 hours before the case. The requirement of an IFU in there, requirement, but it's a battle with vendors. And so for people in our roles, you're consistently on top of vendors about this. So as they change their methodology and their logistics of delivering trays and being able to be that resource, we have a tougher time trying to get, there's almost no inventory. We used to inventory everything. We still require that inventory as it comes in. It's also bringing loaners in. You bring loaners in. Oh, let's keep them there for a couple days. No, we sign them in for in and out. There is no long-term loaner coming. It's that type of, industry thing that used to be done years ago that people in management need to be very, very on top of and really stay on top of these processes. And you need to have good leaders that continue that, every day, every shift, because it is a consistent struggle.
Can I turn this over to Jardine maybe and ask about the surgeon's involvement? Right, we're talking about gaps, and I'm kind of running through my mind, that loaner scenario, and thinking, well, the person who could get the vendors and the reps to do what should be done would be the surgeon. But then I'm running through my mind the number of conversations I've had with surgeons who are just like, oh, just process it how you always process it, Has that been your experience? Can you give any insight around how we can leverage that surgeon relationship?
I would definitely say, try to talk to those surgeons just on a very human level. I am very, very human, and so I approach people in that same spirit and just helping them to understand they're not your friends. And I've had to have that conversation, argument with a number of people in this industry. They are not your friends. You work with them, you like them, but they are not your friends. And when you understand that they are not your friends, then you will be able to separate your work relationship from your personal relationship with these people and make them more compliant to what we need as a work relationship. And I think that's usually what the issue is that people don't know how to differentiate between me having to like this person and me being able to get this person to be compliant with what I like. Right. And so oftentimes they there's they're outlaws. They can do literally whatever they want to do because they have the support of that doctor, and the doctor will throw a fit and will say a bunch of stuff that threatens the likeliness of the hospital, and so oftentimes our department is scared to really hold the reps to the fire because we don't know what that's going to look like for us. But we have a relationship with the doctors as well, and helping them to understand for us to all get what we achieved to get here, we have to work together. And that may mean that you have to let me put some pressure on this rep because, again, that's not your friend. That's your work business partner. That's not your friend. Right. And so,
that's great.
I would say that. Also, I wanted to bring up the fact that there's another caveat I think sometimes that goes a little missed, is that sometimes non-compliance with IFUs has worked in our favor. There are times when techs have not done what the IFU suggested, but they achieved the result or better results than if they had followed the IFU. And some may say, how is that possible? Because if we followed the IFU, it would have taken us 45 minutes to do this. And it's possible that I've been achieving this result for years at this point in 20 minutes. And so it's actually worked to our advantage that we didn't follow the IFU. And so it goes back to my initial point, is that sometimes the manufacturers have overcomplicated what should be done to achieve the result of sterilization or, disinfection.
Or when a manufacturer recommends in an IFU, this is always one that sort of frustrates me. When you see a manufacturer recommend a specific enzymatic, a specific brand name, which they are not allowed to do. It's either a neutral pH, but it can't be a specific brand. They're not supposed to recommend a specific brand in their IFU. That's a conflict of interest. So, that confuses people sometimes. It confuses technicians when they read it. Well, I can only use this and we don't have this product. It's a neutral pH. It doesn't have to be John Smith's neutral pH. So it's there's a lot of complexity. There's a lot of politics built into IFUs sometimes, from a business perspective. So that's some of the things, I would always suggest that they really take a look at. And, there's a lot of legalese around what we do too. Not only do we as, experts in sterilization, high-level disinfection, reprocessing, have to know our industry, have to know our craft, what we do every day. We need to understand materials management. We need to understand the legal part of what we do. We need to understand having the correct documents on hand. We need to understand regulatory affair. There's risk management. It's such a complex piece as you rise up from technician, moving up through leadership, to director level or whatever. You grow with it, but you have to know so many pieces of an industry. And what I stress to students sometimes is that is how our industry grows. You have the opportunity to be a technician, grow maybe to a tech 1 or a tech 2, and then move up and become a lead. And there's so much growth in this industry right now. I don't think it's ever been more wide open. So I think that's the piece we push. Again, back to certifications, back to compliance, back to the things that we need to do. And I think for us, and I am a very blessed individual, I have an organization that supports what I do tremendously. And I think that for us, the more your organization is behind you and what you need to accomplish every day, that is a blessing for all of us and helps us to be able to move on. And I think having that backup in what you do every day, an industry and an organization that wants to always put patients first and do the right thing, is a huge blessing for all of us. And I'm very blessed in that. So
I want to segue off of that risk comment, because you listed risk as one of those collaborative partners that you should bring into this conversation. Yeah. And we've talked a little bit about, what are the biggest gaps or what are the risks involved with loaner instrumentation? That was one of the topics, but what are these other instruments that we know, like if we were to categorize the high priority risk of non-compliant IFU, it's one thing if it's a mallet, right? Like it's going to be real hard to screw up that IFU for processing mallet, but you go from a mallet all the way into the complete other end of the spectrum, that it is very, very easy to, if you miss one step, the whole dominoes comes down. So like, what are those categories? We can just kind of shotgun out, some examples.
Eyes.
All right, flexible endoscopes, eyes.
Okay.
Da Vinci.
Robotics.
Lumens, robotics.
Robotics.
Great. Yeah. Anything else outside of those
I think
categories?
eyes are really difficult.
I've got an interesting question about IFUs that I've come across, and I'd like all your guys' opinions on this. So,
Sure.
you guys know how Amy redid the ST79 and did the amendment for insulation testing on laparoscopic devices.
Yes.
To me, the robotic instrumentations would go into that field, into that spectrum. However, there's no way, and there's nowhere in the IFUs where it states that we have to insulation test. And if you go and start doing some research on robotic instrumentation, because I went down this rabbit hole when I couldn't find the IFUs, there's a bunch of lawsuits that are happening right now from insulation failure burns because there's not any laparoscopic, insulation testing for robotic instruments. So, what do you guys think about that?
Go back to it. We were only required to do long endo instruments before, and all the insulation testers, are built around a certain level.
There's not even attachments for it.
Well, that's exactly right. So it's the insulation testers themselves were never meant for let's say, bipolar forceps or anything. It's just for long endo instruments. So
now we're having to do bipolar forceps.
When you do bipolar forceps, you'll hear from technicians, over time, and I've heard it over time. I've heard it from people in other organizations. But the IFU for an insulation tester doesn't require you to. Yes, but this is the requirement now with Amy. So we need to start doing this. These are insulated instruments. And I had to go out and actually purchase new equipment to be able to have something that was applicable for insulation testing for bipolar forceps. Really look at our bipolar.
As well.
Right.
As these changes happen, that's per the IFU. But the IFU in this case,
and the continuity testing too. We had to buy special stuff for continuity testing.
Right.
The IFUs for the bipolar forceps don't meet, are not concurrent with what Amy is saying. So you always have those gaps in practice, and you have to be on top of it.
Ken?
Conflicting IFUs.
Yeah.
That is a
one
big
says
issue.
soap and water, and one says 9 steps.
Yep, or one that says you don't have to insulate test, but one says you do. One says use this one says use that one. There's all kinds of conflicting IFUs out there that cause non-validated processes to be done because that's what we've always done. That's what is here. That's what's available. You get a brand new robot and you don't have everything you need. So how do you get by?
I love that
we have to get our robot stuff in based on what we have before we do that, and that's why we need to get that buy-in and be part of that.
There you go, and that's what I mean.
Exactly.
Yeah, use the IFUs to leverage that conversation as well. I was going to say, this tied in exactly to what Jardin said, and actually to clarify it for me a little bit, because I've been thinking that you mentioned kind of going beyond the IFU, and I just kind of stuck, and I was just like, okay, what's a real applicable example of that, that you're going in a direction that's good as opposed to going off to something that's not necessarily validated, but this point about insulation testing is key. And it goes back to what you said earlier about critical thinking. If we're sitting there, not robots, we're saying, hey, these devices are insulated, there could be a chance of some kind of patient burn, fire risk. If we have the tools, or maybe if we don't have the tools, perhaps we need the tools to be doing this, even if the IFU doesn't say to do it. Our critical thinking kicks in, and then we become the leading edge of the industry for patient safety, as opposed to constantly waiting. And this is the fun conversation about standards, right? They're 5 years behind innovation and products and processes in the industry. They're saying things that probably should have been happening 5 years ago, but now they're finally updated into the Bible, and now we can do them. So it's connecting all of those dots, kind of to something that Andy said at the beginning is that's why these conversations are critical for moving the needle, because the drive has to come from front end users who are waving a flag saying, oh, no, this isn't working. We don't have the resources. We don't have the inside. This is not consistent, to Ken's point as well. All of that's got to be coming consistently from us to the manufacturers, not from the manufacturers to us, to the standards committee. 5 years later, standards committee come back, and then we give feedback on that, then finally gets back to manufacturer. That's too long. That's not a good
And so-
process.
Yeah, Hank.
Not only that,
Oh, go ahead.
Go ahead.
I was just thinking, Hank, on that. If you think of the manufacturer, they did their job. They designed it. They get it validated, and it might have been 5 years ago, and they got it checked off, right? And from there, they go to sell it to American hospitals. And that IFU is really seldomly ever re-looked at unless we challenge them as an industry. And to get an IFU redone from a manufacturer, that's a big deal for them. So a lot of the times they're going to push us aside and not hear us and listen to us. But I think if enough of us step into it and continue to bother them, I would say, to help them better understand from a user perspective, certain things make sense to us. And we would like to see some changes within the IFU.
I think during that manufacturing process too, to piggyback on what he's saying as well, having us involved in those things as they're manufacturing these things and making these things, like that is the root cause, right? If we root cause all of this, involving us at the end of everything, like, oh, we've developed this, it works for the OR, it works for everybody else, but at the end of the day, we don't have what we need to process it right. Well, we're not going to be giving our patients their best safety and best outcome. So I think these manufacturers need to start teaming up with sterile processing people, techs, all of us, first line people, and see what is feasible, what is it, and how can I get that 510K clearance the right way.
I don't understand why they don't use us as consultants.
Much agree with it.
This goes back to what I was saying about the question of reality. I had a situation some years ago where we had a leg positioner that had bioburden in it, and it was at a point where the leg positioner said on the positioner itself that you are not to take this apart. And so
but that's
we
the
called
way
the
you get the meat
company.
out.
Yes. And so we called the company, and we
I know which one you're talking about.
Yeah. So we said, hey,
no names,
guys,
no
you
names,
told us don't take this apart. And they said, well, everything that is in there at this point, it's sterile bioburden. And so we said, well, there is no way. Why do you think that it's sterile bioburden? Because you sterilized it. And so we explained to them that you can't, cook something that is not clean and then call it sterile because it's not clean, and clean is the actual physical debris being removed. And so they later on made an addendum and said that we could take it apart, and then we got specialized people that we only wanted them to take it apart. But this goes back to my thing about reality. There are things that you think are going to happen, and there are things that are actually not going to happen because nobody's going to do that. And so I agree with you that the manufacturers have to be on board with the frontline workers to determine what reality actually is. And is it going to really work if we do all of these things that you suggested? And then it takes away from us the premise of having a suggestion. We don't need to critically think if you've worked within our realm of reality. But if you're not working in our realm of reality, now you're relying on me to use my logic on how I should do this. I want to also say that I think it's really important for us to take away the heinous of non-compliance. The heinous of not for it to be a malicious thing or it to be an evil thing. If it is an evil thing, it sometimes is a necessary evil. And so in certain situations, for us to take apart that machine, or us to take apart that was non-compliance, but it saves the patient. So it's not exactly a bad thing. It's not exactly a heinous thing. It's just a thing.
Well, it's a bad thing if you have to do it because the manufacturer didn't do their validated testing. So I totally agree. It's not bad to do the right thing. It's bad that the right thing wasn't done at the very beginning to create that. So just real quick, we got about 5 minutes, so I definitely want to wrap this up, to give some practical takeaways for folks, and then we'll let everybody kind of give their 2 cents. We've been talking about the challenges, right? I think all of us, anyone listening to this, is quite aware of them and probably nutting their hair the entire time. But I definitely want to give some tangibles, and we've given some of them. The critical thinking has come up, the communication amongst our team, amongst surgeons, vendors, but directly to the manufacturer. Like, that theme is loud and clear. What are some other must-haves? And let's just kind of go around the horn here and maybe give like one of your must-haves in building it a compliant IFU documentation process and tool in your department? Like, what is that one thing that you would say? Not that there's only one thing, you know, but just give me one thing where you would say, yeah, this needs to be a part of us getting at least closer to that goal of 100% safety and compliance for all the IFUs that are correctly written. Okay, Jordan, let's start with you.
I would say an establishment of general norms. When I look at this IFU, I want it to say cavitation. I want it to say machine washable. I want it to say very user-friendly words that let me know I can do these things versus me having to decipher what I can and can't do.
Great. All right, Michelle?
I would say, agreeing with that and going a little bit further, having it be where they can easily, it's not 500 pages, right? A certain camera can have 150 pages in the IFU. I only need one page to tell me how I need to wash it, how I need to, you know what I mean? So shortening it and having it pertain to just what I need for my stuff.
Mm-hmm. Great. Andy?
Am I allowed to talk product, Hank?
No, but you can talk idea.
Yeah, I'll talk about an idea. I feel real-time IFU guidance, calculated built-in timers for each of the steps, detailed communication for each of the steps, warning alerts, training videos, educational concepts. End result is documentation that gives us a document that proves that we are compliant, and then ultimately digitally added, making this immediate access to all users at a sync level, so it eliminates all the guesswork.
Okay, great. Yeah, we didn't talk about documentation too much on this conversation, so that'll have to be round two. Lisa?
Really, I would love to see vendors start to use sterile processing, maybe management professionals as consultants with their teams to be able to come in and give, tagging on to what everybody has said here, real work process life, what we live every day, and work that into it. If I talk about a little bit about what they were talking about with the leg positioner, you clearly have a vendor who doesn't understand sterility. If he's saying, well, if the bioburden doesn't matter because you sterilized it, he clearly doesn't understand the concept behind sterility. Well, that frightens me if you're validating your own equipment. So,
and what are you teaching your reps, your sales reps, et cetera?
What do your engineers know about this? This is very frightening. So, us being a part of their process would be wonderful. I think that would be extremely helpful because it allows us to create real world work process through these IFUs. That's something I'd like to see.
Yeah, no, that's great. And Ken?
If I had to pick one thing, I would say making sure availability of IFUs. I've ran through a couple companies where the only IFU you'll ever get is that little piece of paper at the bottom of the box when you buy the instrument. That's not online.
You mean the one that talks about lumens and it's not a lumen instrument?
You can't Google it. I'm famous for Googling, trying to find stuff. You can't find it anywhere, but then you dig in a box that you just threw away and you find just that little itty bitty IFU that's folded up 6 times in the back corner of the box. If we could have another software out there, we do have multiple companies that, put all the IFUs into one area, but to have maybe a centralized database that every company is required to put their IFU in, that would help small hospitals that maybe can't afford the price of a monthly or yearly subscription, something on that. It's just something, that anytime a company submits for 510K or anything and they get their IFUs approved, let's just say it runs through the FDA, they have a database where you can just go there, search it, and it's there. That way you can have every single IFU that you need. Might not be the easiest to navigate at that point, but it's available.
Right. Great. Well,
really good idea.
This was a fantastic conversation. I want to thank each and every one of you for being on the panel. Obviously, I want to thank the audience for tuning in and all the great conversation that's happening in the comments section. I'm going to tell you a hack. Okay, so this is a true Beyond Clean style. And I'm really surprised more people don't do this, but I'm going to encourage you right now as you're watching It's on LinkedIn, YouTube, or Facebook, especially LinkedIn in particular. If you're watching on Facebook, go to LinkedIn and do this. Tag your favorite manufacturer or your least favorite manufacturer in terms of IFUs in the comments section. Tag their corporate page. It's going to pop up on their marketing manager's radar. They're going to go see what this big conversation is about IFUs. Hey, tag FDA. And I'm not just talking about one time. If all 300, 400, 1,200 folks who watch this session tag FDA, guess what? Somebody in FDA, or multiple people in FDA are going to start watching this and saying, holy crap, we had no idea the issue was this big, or it was being talked about this transparently. Same thing with the manufacturers. I don't just want to see one manufacturer tag, guys. Get in there and go tag crazy on these manufacturers that are causing you the biggest headaches or are doing it right. That you feel like, yes, thankfully someone has figured out how to break this IFU code. I can understand this. My technicians can understand it. Tag those folks too. Tag your friends, tag your family, tag everybody that you want to know the dirty secrets of IFU noncompliance. Thank everyone again for tuning in. As a reminder, this is the pre-conference session for PYROTECH 2021 that airs tomorrow live. If you're not registered for it yet, it is a free virtual global conference. Go do so at educate.beyondclean.net/PYROTECH 2021. And until next time, keep fighting dirty.